Good morning. I'd like to call the meeting of the Minnesota Senate Health and Human Services Committee to order. It's Wednesday, March 8th, 2023. We do have a quorum present, and we are going to take up the bills in a little different order because we have authors who are presenting in other committees and one who's running a little bit behind. So I'm going to start with my bill 2437.
Senator Wiklund, proceed when you're ready.
Thank you, Madam Chair. This bill is very brief, and it is intended to repeal some obsolete language. It is also one that I would like to pass out of the committee to the floor, and then we will have it available for work with the other body who Chair Pinto will also be taking the bill up. So if there's any questions, I can answer those.
So Senate File 2437 is before us. Questions, members?
Madam Chair.
Senator Abler.
So I love the shall and must debate, Senator Wiklund. Could we have a long discussion about the critical importance of using either in the most correct manner? I see you've changed shall to must. And I'm just kind of kidding, but I appreciate the bill, and I know what you're trying to do. So I think it's a fine bill, and I think must is much better than shall. So I'm totally in favor of the bill. Thank you.
Senator Wiklund.
No comments. I preserve my ability to use shall if I have to, but in this case, we'll use must.
Other questions or discussion, members? All right, seeing none, do you have a motion, Senator Wiklund?
Yes, I'd like to move that Senate File 2437 be recommended to pass.
All those in favor say aye.
Aye.
All those opposed? Motion passes, and the bill is on its way.
Thank you. Thank you, Madam Chair.
And I will hand the gavel back to Chair Wiklund.
And we are still missing our other bill authors, so we will move to Senator Murphy is here, and we will take up Senate File 1561. Good morning. Welcome to the committee, Senator Murphy.
Good morning, Madam Chair and members. How are you today?
I'm doing very well, thank you.
Good.
Please go ahead and present your bill.
Thank you, Madam Chair and members. Thank you so much for making time in this busy week for this important piece of legislation, Senate File 1561, known as the Keeping Nurses at the Bedside Act. I am here today with Carrie Mortrude, who is also a registered nurse and is expert in this legislation. And it is important to have experts in this legislation because in my legislative career, this is an issue the legislature has wrestled with year after year, cycle after cycle, and with each passing term, the bill continues to change in response to the concerns and the feedback that the nurses have received. And that is, I think, the way Minnesotans expect us to do our work, to respond to the concerns, to modify, to compromise, to make change in order to achieve the goal. And I am really proud to be here today with my colleagues in nursing who have done that hard work. I thought about preparing remarks for you, but I decided instead I wanted to talk a little bit about my own practice, which is, a number of years now since I've been in a hospital. But I think it exemplifies what our nurses across the state are experiencing and why I think it is so important to take up this issue. I know that we have a significant amendment to the bill, which represents the changes that have been made since the bill was introduced, and I hope that Mr. Monahan can walk us through that amendment when you're ready. This is the bill's first hearing. It will be an author's amendment, but it is significant, and I think it's important that you know what is there. But fundamentally, this is a piece of legislation to make sure that we have enough expert nurses at the bedside to care for Minnesotans when they're sick. And I think that is a mutual goal. That is a goal for nurses, it is a goal for families, it is a goal for Minnesotans, and it is a goal for our hospitals. And the hospitals continue to be opposed to this legislation, and I know you know that, so I'm not saying anything that's not already abundantly clear. But it is somewhat lost on me that despite the many modifications that the nurses have made, including removing what was their principal goal, a ratio fixed in law, removing that completely from this legislation, there's still very strong opposition from the hospitals. They have removed that fixed ratio in the legislation and replaced it with a series of committees that would work mutually, nurses and hospital administrators, nurses and nursing CNOs together to make sure that there are adequate nurses and that we're building a foundation to retain our skilled nurses in our hospitals. As I have shared before, we are preparing nurses like my daughter, who choose to go to work in a hospital, and they leave soon. They burn out because of the conditions under which they're working. And that pipeline, while it may be preparing nurses, it's not keeping the nurses at the bedside. And we want to keep our skilled nurses at the bedside in our hospitals. And while we have a nationwide shortage of healthcare workers, that is true, and it's not just in hospitals. I think that, to me, is a clear signal that we need to do more within the facilities to hold on to our people, that just pumping people through not only doesn't solve the problem of adequate staffing, but it undermines the goal of a skilled, experienced group of nurses in the hospital prepared to take care of our patients. And study after study shows us that when we have a skilled, experienced workforce in our hospitals, patients get better care, and that should be our goal. When you think about your work in a hospital, and I'm looking at Senator Bolden because she works in a hospital as well, on every unit, in every hospital, on every shift, there is a ratio. It's a simple math equation. There are this many patients and this many nurses. What the nurses continue to say to us is if that ratio is out of balance, they're not able to do their jobs with skill. And they're worried about it. And it is their professional obligation under their license and according to the Code of Nursing that they advocate for conditions where they can provide the care that is safe. Safe being a baseline, not necessarily even excellent. They want excellent. So they are coming to us again for a remedy. And they have done a lot of work and a lot of compromise to bring that to bear on this piece of legislation, which Ms. Mortrude is going to share more with you. And then last, my own experience. My first work in a hospital was in a large regional hospital in the center of rural Wisconsin. Much like you would think about Mayo as a model or CentraCare as a place. It is where the people all over northern Wisconsin and the Upper Peninsula sent their loved ones when they were critically ill. It was a big hospital, 500 beds, and I worked on a big unit, 50-bed unit, med-surg, so we got lots and lots of admissions. And at night, there were usually just 2 registered nurses and then other staff. And by the way, this legislation accounts for and includes other staffing. That's why we have the support of SEIU Healthcare and AFSCME Council 65, because we're not just talking about nursing anymore. We're talking about the complement of staff that's important. So on a night shift, I came in. We had a patient who had just been discharged from the intensive care unit, and he had been intubated, and he was afraid because he thought he couldn't breathe. He needed a lot of emotional support. Down the hall, by about 10 rooms, there was a person who had a cardiac arrest. It was my very first cardiac arrest, and I was the person taking care of him and in the room when it happened, and of course called a code, did CPR until the team arrived, and we lost that patient that night. Across the hallway and down the hall, another 25 beds or so, a patient with an active GI bleed. There were 2 registered nurses on that unit. We called for help but didn't get any help, not for hours. We lost one patient. The patient that was newly extubated was afraid, and he was shouting for us, but we couldn't get to him. And the person who was actively bleeding was eventually sent to the operating room to be cauterized to stop that bleed. We finally got replacement nurses in the very early hours of the morning. That is not an uncommon experience. It is why we talk about nursing requiring critical skills and vigilance, and why we need skilled people working in our hospitals. But the question for us is, as one of the registered nurses that night, had my nursing administrators decided to admit another patient to that unit, should I have been able to say, you can't do it? We don't have the staff. And if they had insisted, what would have happened to that new patient? That's the question that we have to answer. Is it in the patient's interest if we ignore the professional judgment of the nurses in this equation, just to make sure that the nurses or the patients are admitted? We want patients admitted, but we also want staff enough to care for them, to provide the care that they need. And that's what this legislation is about. That is the question before this legislature. It has changed significantly, and so if you hear there is a ratio in this bill, that's not true. But there is a means for putting the nurses and hospital administrators together to make sure that there is adequate staffing. And I believe if we are working on staffing, on reducing workplace violence and making it easier for nurses to go to school and get a degree in professional nursing, that they will find a job in Minnesota. And if they can do their job and do it with professional skill, they'll keep their job and they will stay. And that will be our path forward to high-quality care in the state of Minnesota. I think that is an important value for us as policymakers and an important value for us as human beings if we care about the people of Minnesota, and I know we all do. And with that, I hope that we could offer that author's amendment. We could hear from Mr. Monahan and then turn this over to Ms. Mortrude. Thank you very, very much for making time this morning for this important piece of legislation.
Thank you, Senator Murphy. Members, you have the A3 amendment in your packet. Also, you have the, it's an unofficial engrossment that Mr. Monahan prepared that is meant to be, help you kind of go through what the bill would look like with that A3 amendment applied. So,
Madam Chair.
Senator Abler.
I'll move the bill on the A3.
Senator Abler moves the A3 amendment. Would you like Mr. Monahan to go through?
I would very much like Mr. Monahan to please go through it. Thank you.
Mr. Monahan, if you could go through the amendment. Thank you.
Madam Chair, members, so on the A3 amendment, page 1, lines 3 through 10 are adding language that provides authority to the Commissioner of Commissioner of Health to enforce the new staffing committee language that's in Article 2 of the bill. Lines 11 and 12 specify that the concern for safe staffing form will be developed by the Commissioner of Health. Lines 14 through 16 are the first of a number of requests from the Department of Health that the language specify that they are not required to do on-site visits in order to verify compliance with the staffing committee requirements in Article 2. Line 17 removes the requirement that the hospital staffing committees have a system for the submission of concern for safe staffing forms that's anonymous. Line 18 is the first of a number of changes throughout the amendment that are related to clarifying that the nurse workforce committees, that there needs to be one workforce committee for each unit in the hospital. Lines 19 through 27 are conforming changes. Conforming changes related to language much later in the bill, maybe it's Article 6, about the nursing workforce report. Lines 25 to 27 are, again, related to clarifying that the workforce committees are unit-specific. 28 to 29, again, is that Department of Health language about not requiring on-site visits. Line 30 is, again, related to the workforce committees being unit-specific, as is all the language on page 2, lines 1 through 10. Lines 11 through 15, again, are Department of Health requests that the language clarify that they're not required to do on-site visits. Line 16 clarifies that the core staffing plans need to be submitted to the Commissioner of Health. On line 18 through 20, again, is MDH language about on-site visits. Lines 21 is just correcting the reference to the Commissioner of Labor and Industry. Lines 22 through 23 are correcting a drafting error related to who receives a report from the hospitals. Lines 24 to 25 are related to language involving the failure of a hospital to report when an elective surgery is performed when the hospital is not in compliance with its core staffing report or plan. Lines 26 to 27 are ensuring that if the Commissioner of Health imposes an immediate fine, the hospital still retains its appeal rights under the existing hearing structure. Line 4, over onto page 3, line 1 to 3 is clarifying that the Commissioner of Labor and Industry shall enforce the section about retaliation. So on the amendment, page 3, line 4 through 6 is modifying some of the language related to implementation. regarding the concern for safe staffing form that the Commissioner of Health needs to develop and make available electronically. So beginning on line 7, we're now into Article 3. This is the workplace violence language and the action plans related to that. Right. Line 7 is replacing an implied requirement that a hospital have a computer system to document reports about workplace violence, and instead just requiring them to have some system. May not need to be electronic. Line 8 concerns, is clarifying change about staffing requests. The staffing requests contemplated in that subdivision have to be directly related to reducing the risk of violence. Lines 3, page 3, line 9 is related to the public disclosure of the action plans. Senator Murphy is removing the requirement that the plans be made publicly available and removing the requirement that they be placed on the hospital's website, and is instead substituting that the plans must be made available directly to the direct care workers and then reinstating the language that it must also be made available to representatives of a collective bargaining unit. Lines 13 through 15 are related to a legislative report based on the action plan submitted by the hospitals to the Commissioner of Health, modifying and clarifying the dates that the report is required. And line 17 says that the requirement to submit the reports does not expire. Lines 18 through 19 are related to the penalties for failure to comply with the action plan requirements. It's specifying then that the Commissioner of Health can impose a fine without first issuing a correction order. But then also we're adding language, or Senator Murphy is adding language to allow a facility 30 days to correct a violation before the commissioner assesses a fine. Page 3, line 22, deletes all of Article 5. And the reason that's being done is rather than create a new loan forgiveness program independent of the existing health professional education loan forgiveness program, the language about hospital nursing is going to be incorporated into what was Article 6 of the original bill. So what begins on the amendment on page 3, line 23, is the new combined language from original Article 5 and original Article 6. The amendment there creates a loan forgiveness program for, on the one hand, nurses who agree to work in nonprofit hospitals providing direct care, and the other clarifies and sets a mechanism for dedicating money for nurses who agree to teach. That's most of the amendment. Then there's some conforming changes after that. That brings us all the way up to page 11 of the amendment. Those are existing appropriations in the bill that have been reworked and reworded because of the way we restructured the loan forgiveness program. Brings us to page 12. Lines 12.2 to 12.22 create a new requirement under the adverse event reporting system that requires a facility, when reporting an adverse event, to also document in the report whether the unit on which the adverse event occurred was in compliance with the core staffing plan at the time the adverse event occurred. Lines 23 through 28, on to the next page, 13 through lines 8, requires the Commissioner of Health to work with the Minnesota Nurses Association and other professional nursing organizations to develop analytical tools to try to determine any causal links between adverse events and understaffing, and requires a report by January 1st, 2026. And finally, lines 10 through 21 require the Commissioner of Health to develop a report to describe the current status of nursing in hospitals. That concludes the amendment.
Thank you, Mr. Monahan. I do see, I was alerted to, I don't want to imply that I found this, but I was alerted to on line 13.12 of the amendment, or 13.13. I'm sorry. There looks like there's a word that, it says amendment, but maybe it means it should be report. Should we?
That's correct. That's not the only mistake.
Oh, it's not. Shall we correct that, or shall we wait and do all of
If we
them?
want to orally amend the amendment by correcting it, I've got a couple others we could do too.
What's your, would you like to take care of all of this at once and get all of the corrections if you have them?
Madam Chair, if you are willing to do that with Mr. Monahan's help, but thank you, Mr. Monahan, I would love to do that and get it into the shape it needs to be in.
Okay. Do you want to start with where you noted the first thing you want to change, or do you want to start with this one?
We could start with this one, Madam Chair.
Okay.
Madam Chair,
Senator Abler.
if you want us to expedite, he could just give the list, and I could just incorporate those into my amendment.
Okay.
Thanks.
Mr. Monahan?
Madam Chair, Senator Abler, the first change would be page 13, line 13, delete amendment and insert report. Sorry, I didn't prepare this ahead of time. So on the amendment, on page 3, after line 8, insert page 20, line 24, delete public. That was the other one that I had in mind, Madam Chair.
Madam Chair, I can incorporate those.
Do members understand the changes that we wish to incorporate as oral amendments to the A3 amendment? Okay, then all those in favor of the oral amendments to the A3 amendment, please signify by saying aye. Aye. Any opposed? The oral amendments are adopted. Now we're back to the A3 amendment. Any questions before we vote on that? Seeing no questions, members, all those in favor of the A3 amendment, please signify by saying aye. Aye. Any opposed? The amendment is adopted. Senator Murphy, now we have the bill in the shape that you would like it to be in. Would you like to move to your testifiers? What we have today, we have, let's see, 7, is it 7 and 7? We have 7 in support and 7 in opposition. We're going to start with in support, and each testifier, we will allocate 3 minutes. And we'll have, Ms. Ryan will do the timing. Our first testifier in support is by Zoom, and it's Steve Romanesco. Welcome to the committee, Mr. Romanesco, and please state your name and begin your testimony. Oh, and just a second, we are not hearing your audio. Do you see any reason?
Can you hear me now?
Yes, we can.
Okay, wonderful, thank you. So my name is Steve Romanesco. Good morning, Chair Wiklund, Senator Murphy, and members of the committee. Thank you for inviting me to speak in support of SF 1561, the Keeping Nurses at the Bedside Act. I was asked to speak to you all today due to my extensive experience and difficulty with the current healthcare system. At 34, on top of my career in higher education, I've been a professional sick person for over 2 decades now, since being diagnosed with primary sclerosing cholangitis, a progressive liver disease that's brought with it 2 liver transplants, and ulcerative colitis, an irritable bowel disease that caused my colon to need to be removed. As you can imagine, I've been a frequent flyer in the hospital for most of my life. A simple fever for most causes a trip to the ER and generally a few days admission in the hospital for me. Over the past year, I've been to various emergency rooms across the metro area 4 times for various reasons. At all these visits, I noticed nurses dealing with greater patient loads than I was used to, and in cases of admission, a much greater wait time to get into the hospital. I waited in the ER waiting area for over 8 hours one visit and waited 24 to 36 hours depending on the time or depending on the visit for a room to open up for me to be admitted. On the floors, I noticed rooms sitting empty due to lower staffing levels while my nurses had greater than normal patient loads in double rooms. Rarely when I go to the hospital do I fear for my life. However, lately it hasn't been the case. I was not receiving the best care I could because of the stress on our medical system and on some of our most important pieces of that system, nurses. It is clear to me that we as a society need to take better care of nurses who have given so much to us and have been so critical to my ability to survive and thrive. The Keeping Nurses at the Bedside Act does just that, helps set safe staffing levels for critical care patients such as myself, keeps patients outside of the hallways in the ER, prevents violence to nurses, and strengthens the education to nursing pipeline. I urge this committee to support this critical bill for all Minnesotans. Thank you all, and I cede my time.
Thank you very much, Mr. Romanesco. Next, we will have, I'll have Mary Turner. Please come forward. Welcome to the committee. Please state your name for the record and begin your testimony.
Good morning, Madam Chair. This is like deja vu here. My name is Mary Turner. I'm an ICU nurse and currently serving as the president of Minnesota Nurses Association, and we represent 80% of the hospital bedside nurses in Minnesota. As you likely know, during our recent statewide contract negotiations, staffing was a central sticking point between workers and management. Nurses sought not only a greater voice in staffing and scheduling decisions, but accountability from our healthcare systems when those staffing levels are not met. Time and time again, our employers told us that they would never put that sort of staffing language in our contracts, and they would have to be directed by the legislature to do so. The best language any hospital received only prevented staffing from getting worse than it already is, and those current levels are unsustainable. We have done all we can through negotiations. For over a decade, M&A has come to the legislature asking for help to make staffing at hospitals safer, and I can attest to that because I've been there every step of the way for the past decade. Today, the need continues to be dire as nurses work on the front lines in short-staffed units with increasing violence, abuse, and trauma. With unsafe staffing, increased patient health needs, and escalated stress from living through a global pandemic, we are seeing more and more challenges in the hospitals, and nurses continue to take the brunt of all of this. We see this all come to a head with the increased violence and abuse we experience. A recent study last spring from the Press Ganey National Database of Nursing Quality Indicators shows that for every hour in the day, 2 or more nurses are assaulted. I repeat, 2 nurses are assaulted every single hour by patients, family members, and visitors. And this brings to mind when I was during negotiations at a rally, and I get a text from a nurse from my floor that says this, and I hope to never have this again. She says, "Mary, I almost died today at work." She had been severely assaulted by an intubated patient that had gotten out of their restraints and trapped her in the room. I worked with this nurse just the other night, and as nurses go, we were reminiscing about the pandemic. And she was talking about her increased alcohol abuse and how much she has the PTSD. This is very real for us, having been in a COVID ICU from the very beginning. Every day, nurses are put in work situations where they relive their own experiences of violence and abuse, only further exacerbating their trauma and causing deep issues with their mental health. According to a literary review of clinical articles spanning the last decade, 96% of nurses experience at least one symptom of PTSD. Female nurses have doubled that risk of suicide compared to women in the general population and are 18% more likely to die by suicide. Studies from 2020 and 2021 show that nearly 50% of ICU nurses were at risk for having PTSD paired with increased severe depression and anxiety diagnoses, which increase their risk of leaving the profession. It is not hyperbolic to say our profession is in crisis, but that crisis is not that we do not have enough nurses. We actually have 2 registered nurses for every nursing job in the state. However, we do not have enough nurses who are physically and mentally able to continue in this job without proper support. Without adequate supports for
If you
nurses,
can-
we will never solve
You
this
can
workforce
complete your
issue.
testimony. Thank you.
Thank you for your time.
Thank you very much. Next, we have Becky Nelson.
Good morning.
Good morning. Welcome to the committee. Please state your name for the record and begin your testimony.
Good morning, Chair Wiklund and committee members. My name is Becky Nelson. I've been a registered nurse for more than 20 years. My entire professional life has been focused on providing patient care. I am also the chair of M&A's Governmental Affairs Commission. This week, M&A released data on why nurses are leaving the bedside in Minnesota. But before we even get to the why, I really want to highlight one number, 2,400. That is how many M&A nurses left a bedside hospital job in the last year. That is a retention crisis. It means veteran nurses are retiring early, taking years of experience with them, and it means new nurses are being turned away from a career that they spent years earning a degree for, only to find out that the job was not really what they signed up for. And make no mistake, there is no shortage of Minnesotans who want to work as nurses. In 2022, there were more than 122,000 registered nurses in Minnesota, which is an increase of more than 4,000 over the previous year. Over and over again in these responses submitted to our survey, we saw nurses say that they miss the hospital, that they really never wanted to leave bedside care, but the conditions that they faced there made it impossible for them to stay. In our new study, fewer than 1 in 5 nurses said they would not return to the bedside under any condition, and that includes those who have retired. That means approximately 2,000 Minnesota nurses are ready to return to the bedside if conditions improve. In the nearly 500 nurses who responded to the survey, the number one reason they identified for why they left the bedside was insufficient staffing, followed by stress, management issues, and poor working conditions. These responses were mirrored when nurses were asked the top issue that needs to be fixed for them to continue or to consider returning to the hospital. Nurses far and away identified improved staffing as the most critical issue to nurse retention. The actions of our employers can make or break the will to stay at the bedside. Instead of working to retain us, we are being used up physically and emotionally. We're not a billable line item. We're not robots. We are highly skilled professionals and we are people. We need to be treated as such and we need a voice at the table to help make these improvements and ensure patient care is the top priority. Thank you for your time. I urge you to please pass SF 1561 to help fix staffing in our hospitals and bring nurses back to the bedside. Thank you.
Thank you very much. Next, we have Kirsten Price.
Good morning. Thank you for having me. Shall I begin? I can begin. Okay, great. Good morning. Yeah, my name is Kirsten Price. I am a registered nurse, and I am here today on behalf of the Minnesota Nurses Association. I'm here to provide testimony in support of keeping the Nurses at the Bedside Act. I've been working in a hospital setting for 10 years now, with my most recent position in an ICU in Minneapolis. I'm a recent transplant from California, where robust laws around nurse staffing levels have been in place for more than 20 years. In my time working as a bedside nurse in California, not only could I care for my patients in a humane and dignified way, but never once did I feel that I was at risk of losing my license due to unsafe patient assignments. Since moving to Minnesota, however, I am concerned by what I have witnessed in regard to unsafe staffing and the effects that it has had on the patients I care for and the nurses that I work alongside. During my time in Minnesota, there have been countless unsafe situations that could have resulted in sentinel events, which is a patient event that results in death, permanent harm, or severe temporary harm. These situations include times when nurses had to take on more patients than what is medically safe, leaving us to put our licenses on the line, and worst of all, our patients' lives at risk. In my hospital, there are instances when charge nurses have to take patient assignments, but are also required to respond to unexpected cardiac or respiratory arrests across the hospital, oftentimes leaving their patients without a nurse to care for them. Oftentimes, patients are left without the care they deserve, or a nurse is forced to miss their only lunch break in a 12-hour period due to a lack of staffing. Unfortunately, I'd say that it's become the norm. If you wonder why nurses are leaving the bedside in droves, look no further than the soul-crushing feeling of the inability to provide safe and humane care to patients during their most vulnerable and life-threatening moments. One of the primary goals of Keeping the Nurses at the Bedside Act is to address the crisis of understaffing in Minnesota hospitals, starting with the establishment of nurse staffing committees and the ability to have meaningful voices in what safe patient care looks like in our hospitals. If you feel or expect the patients deserve a high standard of care, then you need to act now. In passing Keeping Nurses at the Bedside Act, you will be demonstrating to your constituents that they deserve to be taken care of with dignity and respect, and at the end of the day, keeping more nurses in roles of care. Thank you.
Thank you, Ms. Price. Next, we'll hear from Wendy Wall, and after that will be Amber Hardwig. Ms. Wall, please introduce yourself for the record and proceed with your testimony.
Thank you for being willing to listen to my testimony. My name is Wendy Wall. I work in a rural critical access hospital, Sanford, Thief River Falls. I'm a nurse of over just 20 years. Nurses are exhausted, and many of us are quietly, slowly walking away. Understandably, over 2,000 nurses have left the bedside. Many of these nurses are standing on the sidelines, watching, waiting, ready to return if working conditions improve. We are all waiting for working conditions to improve. 16 of 54 inpatient positions are open at my hospital. 16 of 54. We are all waiting for working conditions to improve. But the staffing solutions being offered by my management, replacing 3 open registered nurses positions with nursing assistants. These positions are currently being covered by people who already work there who are registered nurses. All non-OB charge nurses needing to become competent in caring for babies as they are born so they can decrease minimum staffing ratios. These things do not improve working conditions, but make them worse. Management tells me there is no financial need to cut nurses, but instead of offering to match starting wages with all the surrounding hospitals, or offering to offer a sign-on bonus to attract nurses, they are posting many positions requiring applicants to complete nearly $1,000 worth of classes to be eligible to apply. Because of these things, I know I cannot count on my management and my hospital system to protect my patients and my community. So I am asking you, legislators, to protect my patients and community. Ensure Minnesota hospitals look out for the community's best interests, are accountable, and are transparent. The Nurses at the Bedside Act accomplishes these goals. It requires meaningful discussions about staffing, posting of staffing plans to the public. Patients and communities have a right to easily know how their hospital is staffed. They have a right to know. Then patients will be able to use their dollars to incentivize the hospitals to do the right thing. Thank you for your time.
Thank you for your testimony, Ms. Wall. Next, we will hear from Amber Hardwig, and after that, Carrie Mortrud. Ms. Hardwig, welcome to the committee. Please introduce yourself for the record and proceed with your testimony.
Good morning. My name is Amber Hardwig. I'm a registered nurse who lives and works in Duluth, Minnesota. I drove down this morning to speak on behalf of Minnesota Nurses Association. We need legislation to help keep our experienced nurses at the bedside. In some of our union contracts, we have tried to address unsafe assignments and short staffing. However, there are no actionable solutions for nurses or consequences for hospital executives and management. Unsafe staffing reports are filed, they pile up, and nothing changes. Nurses have tried to do everything we can within our contract language, but the problem persists. In my hospital, there are often shifts where management has scheduled 0 core nurses. That's 0 nurses that were hired to that floor. Instead, management relies on float nurses from other departments or travel nurses who may have never been on that unit before. The number of beds in our hospital is a static number, but the number of staffed beds fluctuates based on shifts and staffing grids. There are often empty rooms with beds, but nobody to staff them, so we are told there are no beds. Our emergency department routinely holds multiple patients waiting to be admitted as inpatients for more than 24 hours. Our community and patients deserve better. Our ER and labor and delivery floors cannot turn away any patient regardless of room or staff availability. On my shift just last night on labor and delivery, we admitted 4 patients who each should have had a one-on-one nurse to care for them. There was only 1. Nurses who already had full assignments had to absorb even more patients. Unsafe staffing levels like this lead to delays in treatment, important vital sign changes being missed, like a dangerously high blood pressure or low blood sugar, new moms not receiving the education they need to take home their newborn, call-outs not being answered in a timely manner, pain not being adequately controlled, and nurses never getting a break, which only further taxes our ability to support our patients. These are the conditions causing nurses to leave the bedside. Our bedside staff are morally, emotionally, and physically injured. We are unfortunately walking away from the hospital setting. When that happens, we lose all of the skill and experience completely, and our hospitals need to invest time, money, and more resources into hiring and training new employees. We need you to intervene now to ensure that hospital bedside nurses have the support they need to continue to care for you and your loved ones. Please pass the Keeping the Nurses at the Bedside Act. Thank you.
Thank you. Thank you for your testimony. And last, in the supporter testifier list, Carrie Mortrud. Please state your name for the record and begin.
Thank you, Chair Wiklund, committee members, and Senator Murphy. My name is Carrie Mortrud. I'm the nurse staffing specialist with the Minnesota Nurses Association. Thank you for the opportunity this morning to testify. I gave up bedside nursing over 18 years ago because I couldn't deliver care safely to my patients. The moment I gave up is one I'll likely never forget. When I was told to put one of the 2 cardiac ICU patients in the hallway in a wheelchair because I was receiving a third, I knew then that something in hospital care was seriously wrong. And since then, it's only further deteriorated as nurses continue to struggle on the front lines to provide safe, quality patient care. Hospital bedside nurses are in crisis, as you've heard from the testifiers before me. They are here pleading for the real solutions that Keeping Nurses at the Bedside Act provides. This is a comprehensive solution. You're going to hear about how this legislation is only going to cause further issues with staffing and financially harm the hospitals. Yet research shows that safe staffing levels increase quality of care. The Federal Agency for Healthcare Research and Quality funded research which found that increasing the number of patients per nurse is commonly associated with high rates of non-fatal adverse outcomes such as pneumonia, shock, cardiac arrest, and urinary tract infections. Opponents state that meeting the legislation requirements will financially harm hospitals, yet a study in the Journal of Healthcare Finance by Harless and McHugh titled Nurse Staffing Quality and Financial Performance determined that increased staffing of RNs does not significantly decrease the hospital's profit, even though it may boost their operating costs. The opponents will say that this is a ratio bill. As you've heard many times over, it is not. You may even hear that this bill will kill patients. It will not. You may also hear that this bill will make the ER situation worse, when actually, if nurses on the floors have the appropriate number of staff, they won't have to close their units, which will make the emergency room situation much better. This legislation is different than the staffing bills passed in California. It includes staffing committees, workplace violence reform, and loan forgiveness. While we strongly believe that this is a retention issue, we also recognize we need to keep the pipeline open and encourage nurses to come. Each year, hospital administrators come before you to ask you not to interfere with their business and leave the decisions up to them. And again, today, nurses are asking you to intervene. The old way of doing things isn't working. M&A collects concern for safe staffing data from nurses when, in their professional judgment, they believe patients are at risk for being harmed or have been harmed. And the most recent data we collected last year showed that 90% of the time, when nurses called their management for assistance, there was either no answer or the response was, okay.
If you can kind of conclude your thoughts, I'd appreciate it.
Absolutely.
Thank you.
At the same time, adverse events went up 33% for hospitals last year. That means that Minnesotans were likely to experience having the wrong limb amputated, having surgery performed on the wrong patient, death, or sexual assault. How many nurses must leave before we are heard? How many patients must suffer substandard or even seriously unsafe staffing before we're heard? How many? Thank you.
Thank you for all of the testifiers. Now we will move to testifiers who are in opposition to the bill. The first is Tammy Hayes. Welcome to the committee. Please state your name and begin your testimony.
Madam Chair, my name is Tammy Hayes. I'm the Chief Nurse Executive at Northfield Hospital and Clinics. I have 20 years as a nursing leader and 18 years at the bedside previously. While proponents of this bill believe it will bring nurses back to the bedside, we disagree. Statewide, 57% of registered nurses are not working a full-time schedule. Hospitals across the state are accommodating this to allow nurses to have a better work-life balance. It's something we are happy to accommodate at Northfield Hospital. However, we are still a hospital and need to provide exceptional care to our patients 24/7, 365 days a year. This means we need to hire more nurses to fill those shifts. Minnesota has over 5,000 vacant nursing positions. At Northfield Hospital, we have 15 of them, but it is about 12% of our nurse staffing. We know this workforce shortage does not simply boil down to staffing ratios. This is about patient demographics, care team experience levels, and the acuity of our patients. Not all patients require the same care. The committee process proposed in this bill will not bring nurses back to the profession. If serving on committees entices any nurses to come back to the bedside, it will only be a few. Staffing ratios are not proven to alleviate the strain on nursing shortage. California is the only state mandated nursing staffing ratios, which have been in place for nearly 20 years. California has over 40,000 vacant nursing positions. It is the most in the country. Ratios don't improve quality of care either. Minnesota ranks 4th nationally for healthcare outcomes, accessibility, and cost. California ranks 29th. At Northfield Hospital, if these ratios were in effect, we would likely have to close units, reduce service, and not be able to serve our patients. Thank you for your time.
Thank you for your testimony. Next, we have Mary Beth Olson. Welcome to the committee. Please state your name for the record and begin your testimony.
Thank you, Madam Chair. My name is Mary Beth Olson, and I'm the Vice President of Acute Care Nursing Operations at Allina Health. And my responsibilities include developing strategies to address the acute care RN workforce shortage. Prior to this role, I was the Chief Nursing Officer at Mercy Hospital in Coon Rapids and United Hospital in St. Paul. I have over 39 years working as a nurse. My experience at the bedside includes med-surg nursing, critical care, and the operating room. Allina Health and other metro systems just recently settled their collective bargaining agreements with the Minnesota Nurses Association, and the contract includes components which creates an aligned direction on staffing. The contracts are exceptionally generous. Despite healthcare systems being extremely financially fragile, staffing and supply costs rising, and reimbursements remaining flat. However, we knew this is what we wanted and needed to do for our nurses. Allina Health is opposed to Article 2 of this bill as it moves staffing to a decision by committee that does not allow for real-time decision-making and flexibility, nor accountability to the cost of care or the workforce challenges. The committee is not charged with using any guidelines, standards, or benchmarks in identifying the staffing grids. The bill asks for a committee to meet regularly and decide the nursing staffing ratios. Allina already has a committee process in place, and it functions as an advisory committee. It does not set ratios. Our teams have daily huddles and frequent real-time conversations with our staff nurses and those staff nurses working in the charge nurse role. They make the decisions and recommendations on the staffing needs. Patient acuity can change quickly, and the flexibility to respond rapidly is necessary. In a time when we already have overcrowding of our emergency departments and are boarding patients for many days, some days it's necessary to rearrange our staffing within departments to make sure all patients are receiving the highest quality of care. A ratio would not allow the individualization of care and real-time problem solving in which nurses and the rest of the care team are trained and equipped to do. We ask that the committee oppose Article 2 of this bill. Thank you.
Thank you for your testimony. Next, we have Jerry Schoens. I apologize if I'm mispronouncing that. Welcome to the committee.
Thank you. Thank you, Madam Chair. I am Jerry Schoens. I'm the Director of Nursing and Clinical Services at the Sanford Tracy Medical Center. I've been an RN for 35 years, and I've been the Director of Nurses for 30 of those. I will say all 35 I consider frontline because I am out there with the nurses and everything every day. We are a small critical access hospital. We are one of 78 critical access hospitals in Minnesota. We have 18 hospital beds. Oftentimes, our nurses are covering inpatients, observations, ERs, and outpatient treatments. So we need the flexibility to easily move nurses between all of these needs. We service the southwestern side of the state. Requiring nurse staffing ratios and other regulations set in this bill would add an additional burden that would exacerbate workforce issues within our hospital. I speak frequently every day with my staff about their needs. If I'm not around, they can decide if they need to call in additional nurses that day or reshuffle if some areas are busier than others. This gives the nurses the autonomy to do what is right for patients and for our care team. We empower our frontline nurses. Requiring our hospital to have a committee simply would not work. This would add stress, change the culture of us working together as a team, and would compromise our delivery of care. We would need to ask them to come in on their days off or change their schedules, even if we are paying them. To go to committee meetings would be extremely burdensome. I would never find volunteers to attend these committee meetings. While Article 2's stated intention is to reduce burnout, stress, and unsafe practices, this bill would do just the opposite. Thank you.
Thank you for coming. Thank you for your testimony. Next, we have Sarah Gabrick. Welcome to the committee. Please state your name and begin your testimony.
Thank you, Madam Chair. My name is Sarah Gabrick, and I'm the Chief Nursing Officer at Winona Health. I have been a nurse for 37 years, 12 of those in direct patient care. We are a 49-bed rural hospital, and our next nearest hospital is 30 miles away. We use daily staffing huddles at Winona Health to make staffing decisions in real time, allowing flexibility to adjust staffing and respond quickly to patient needs as they change, including staffing needs of patients boarding in our emergency department. Staffing ratios will not allow quick problem-solving, real-time flexibility, and those staffing adjustments that are absolutely crucial to meeting the changing needs of our patients. Passing this bill will severely limit our patient admissions and our ability to deliver care, resulting in even larger backlogs and patient care delays. This bill suggests arbitration as a solution to resolve staffing challenges, which would also delay response time to patient needs and add cost. Article 2 is not only creating a staffing ratio, it is a rationing of health care. It will be a first-come, first-served model of care. That model will not work in Minnesota, where patients have come to expect exceptional care. One of our values at Winona Health is that everyone matters. Our community relies heavily on us. We are their hospital. Winona Health has deep community roots, triaging, caring, and adjusting to do the best we can with the limited resources we have to deliver on our mission, our vision, and our values. While registered nurses are absolutely critical to our care team, nursing assistants, licensed practical nurses, respiratory therapists, pharmacists, physicians, and others are equally important to providing team-based and comprehensive care. This bill is not right for Minnesotans. It will negatively impact the care we can provide. We ask this committee to oppose Article 2 of this bill. Thank you.
Thank you for your testimony. Next, we have Rochelle Schultz.
Good morning.
Welcome to the committee. Please state your name and begin your testimony.
Good morning, Madam Chair and members. My name is Rochelle Schultz, and I work with Sarah at Winona Health, an independent community hospital where I'm the president and CEO. I'm also very distressed and deeply concerned for my community and my organization. It is our privilege to serve much of Southeast Minnesota's healthcare needs, but our health system is in dire need of more workforce and financial relief. We ended our 2022 fiscal year with an operating margin of -3%, and this isn't due to mismanagement of funds. This is due to the exponentially rising costs for labor, medications, medical supplies, and so forth that are necessary to serve our patients, as well as the inadequate reimbursement that we receive from government plans that is far less than the cost of providing care. Also, due to the workforce shortages, we have been faced with the inability to discharge patients to appropriate care settings, whether that's a nursing home, assisted living, home care, or even home. The effect of patients staying in the hospital longer than medically necessary is our emergency department fills up, and there are longer wait times for patients who need care. All of this is extremely costly to finance. In my 35 years in healthcare management, I've never seen finances and projections so poor. And while 2022 was a tough year, 2023 is projected to be worse, with a potential -6% or more operating margin. If enacted, this bill will make our financial future even more grim. To comply with the proposed rigid staffing protocols, we would need additional help, and there are simply not enough nurses to hire. We are still trying to replace travel staff with our own caregivers. From the pandemic and even now, we know how expensive nurse staffing agencies are, and that is clearly not a viable option for our system. And this leaves us with the only other option of shutting down units and services. Units and services are already being closed, or the number of staff beds reduced to the lack of workforce in many rural locations, and we have staffing ratios already in place. We can't sustain more restrictions. Our community relies on us to be there for them. It is estimated that over 70,000 Minnesotans would be unable to access care if this bill were enacted. And it is frightening to me what will happen to those patients who show up and can't get care. And I'm disheartened to say that many Southeast Minnesota patients that we currently serve would be part of that number. So we ask that you would please oppose Article 2 of this bill and save rural hospitals in our state. Thank you.
Thank you for your testimony. Next, we have Adam Carlin.
Thank you, Madam Chair. My name is Adam Carlin, and I'm the Clinical Nursing Director for Critical Care at Park Nicollet Methodist Hospital. I have a doctorate and board certification in nursing leadership and have spent the last 8 years as a nursing leader and the prior 6 years as an ICU nurse. Methodist is a union hospital and has a long-standing staffing committee responsible for reviewing staffing plans and addressing staffing concerns. In my role as a nurse leader, I often find myself caring for our patients while also caring for our healthcare system. I put my heart into nursing the system back to health, but just like for the patients in our hospital, a massive dose of the wrong medication will lead to a crash. Article 2 of this bill is just such a harmful dose. I appreciate the urge to act, but I am here today because this legislation was developed with the deliberate exclusion of hospital nurse leaders. While there are innovative elements of this bill, such as addressing workplace violence prevention, loan forgiveness, and funding for mental health services, I can assure you that other elements of the bill would open the door to catastrophic healthcare spending with no promise of added value in the care we deliver. We oppose Article 2 of this bill as it threatens to replace existing staffing committees with an impractical, divisive, one-size-fits-all legislative mandate. The bill proposes that unresolved issues would move to arbitration, an untimely process that is typically decided by an individual with no staffing experience. We appreciate the amendment that suggests that hospitals would not create anonymous staffing concern forms. At Methodist, our forms are not anonymous, allowing us to better understand the issues that come forward and address them in a timely manner. Our approach empowers team members to speak up in the moment and to work with their leaders for real-time resolution. Further, this bill directly conflicts with Medicare regulatory requirements that allocate ultimate responsibility for hospital staffing to nurse executives. So I ask you, under this proposed legislation, who is ultimate responsible for hospital staffing? Thank you.
Thank you very much for your testimony. Last on the list is Mary Krinke. Welcome to the committee. Please state your name and begin your testimony.
Thank you, Madam Chair. And for the record, my name is Mary Krinke, and I'm with the Minnesota Hospital Association. Last night, I was struck by the comments of former Governor Mark Dayton. He talked about receiving quality health care in nearly a dozen different Minnesota hospitals, and that Minnesota has become known for its great delivery of health care, and that it is available to all Minnesotans. I'm afraid that if this bill is implemented, it could jeopardize that quality of care and access that we have come to know. I want to address two concepts in this bill that are particularly troubling. The first is bringing in arbitration to resolve both staffing level disagreements and when the staffing complaint forms can't be resolved by the newly created workload committees within 30 days. Arbitration is a legal process in which the selected arbitrator makes a binding decision. Arbitration is used in contract disputes regarding salary and benefits. It's usually when there is a public union, police, and fire. Patients' needs are constantly changing. This would move staffing decisions out of a hospital and eliminate real-time staffing decisions which adjust to patient acuity. Arbitration is costly and will add more time delays and distance from staffing decisions. The second issue that I want to draw to your attention is language in the bill allowing nurses to refuse a patient assignment, and the language that calls for 50% of the nurses on a unit to vote regarding whether to accept an additional patient on that unit. Hospitals can't serve their communities taking votes to determine if a patient is allowed to be admitted. Hospital units will close and patients will back up in hospital emergency rooms, and access to care will be in jeopardy for thousands of Minnesotans. I want to reiterate that MHA supports several of the provisions in the bill. Hospitals want to work collaboratively with all our care teams on reducing workplace violence, supporting loan forgiveness for nurses, and funding for mental health programs for healthcare workers. Our opposition and concerns are all contained in Article 2, which contains the various staffing mandates. I do want to recognize in closing that nursing is hard work, and there are many challenges right now in hospitals. Patient discharge issues, emergency room boarding, healthcare workforce shortages, and yes, sadly, many instances of violence against our employees. Article 2 does not address these challenges and will create new problems of access to care. It is not a solution. Thank you.
Thank you for your testimony. That completes the list of testifiers that we have, and we are able to move to member questions, and I have Senator Morrison.
Thank you, Madam Chair, and I want to thank Senator Murphy for and all the testifiers. I've been furiously taking notes over here. This is an incredibly important conversation that we have to have. You know, I think that I can say as a physician myself who's worked in hospitals in 3 different states that nursing has to be among the most noble of professions, and nurses are essential parts of the healthcare team. You know, when someone has been in the hospital, the people they remember who took care of them are the nurses. The nurses are the people who are with patients all day and all night. The pandemic was incredibly stressful on healthcare workers. I think things were tough beforehand, but it accelerated a lot of the challenges that we've been talking about this morning. And I commend the nursing profession for elevating this concept of moral injury, because it is real, and it has devastated a lot of healthcare workers, and we are left with that, and we continue to struggle with it. And I think sometimes it can almost feel like society is breaking down when you're in our hospitals right now with the stress of taking care of sicker and more medically complex patients, threats of violence, actual violence, a society that's flooded with weapons. These are scary realities in our hospitals, and all of this has led to increased mental health care challenges that we're seeing across the board, not just among our healthcare professionals. And I think that the part of the bill, the $10 million annual grant provision reflects that need, and I was really happy to see that part of it. Workplace violence prevention is absolutely critical. And addressing our statewide workforce challenges has to be a part of this conversation, and the provisions for loan forgiveness and other incentives are key. And I absolutely support the intent of the staffing committees, and I look forward to continuing the conversation with you, Senator Murphy, and all the advocates. And I don't have a question, I just want to express gratitude. Thank you.
Let's see, Senator Abler and then Senator Bull.
Well, thanks, Madam Chair, and I really appreciate the discussion. I wish this was the first discussion we're having on that topic. Like, oh, look at this. Here's a problem. Let's work to solve it. It's been going on for what, Senator Murphy, a decade or longer? There's been every way to Sunday to how about this, how about this, how about that. I never supported ratios, as the people know that we're supporting those, and I just thought it makes sense. I thought let's have committees at the hospitals and sort this out. And kudos to Tracy and Winona for actually doing that. And Tracy and Winona, you don't need this bill. But it seems to me, as I've listened to nurses in my district and other people that have talked to me, is that they don't feel safe at work, and they feel overloaded, and they feel like they're incapable of providing proper care. That, to me, should be a big deal to the people who are in the administration side, who also want to have safe staffing and quality care and people who go to work. And so I just don't understand why at every turn the answer is, well, look at this nitpick problem with the bill. Well, look at that. How can we do that? And I think at some point there has to be a collaborative effort. And this is actually the best effort so far, I thought, that made sense. Let's have committees in hospitals work on it. What if we have a committee that half the people work there and half the people the administration gets to appoint? That seems like kind of a reasonable thing. To me, I don't think anybody wants to go to arbitration, but I think it's just an exclamation point. I think this bill is ripe to be talked about, not in a harsh bargaining context like, oh, we're going to win, you're going to lose, but how can we make nurses feel safe? How can we make nurses feel like they're doing what they're good at? And how can we, luckily for everybody, the public doesn't know how bad at risk they are. And that problem is not a function of the nurses group or the administration's group, it's a function of the times. And so my desire is, Madam Chair, I think leaving this committee, I don't have a bill, but I know there's ideas drifting around about how to handle the hospital compression issues where we can't get people to move out. And there's various ideas about helping nursing homes get a bonus for taking some of the hard-to-serve people. Hennepin County has over 50 people sitting there today that have been there a good long time that don't belong there. And people have to look after them and burn up your profit margins and your beds and waste nurses' time doing stuff that is not useful anymore. And so just what if this was a collaborative effort? And to the administration there, and I have Mercy and Unity in my area, I care about that. I got your notes, and I don't disagree. But it cannot be, every time this comes up, nothing to see here. That's my frustration, and that's why I'm on the bill. I'm happy to move it toward a resolution. Is there a working committee structure that exists in Minnesota now? Sounds like Tracy and Winona have one. Well, then let's put that into the bill. So how does it work? And it seems as though the administrations there are totally in on making sure that good things happen. So it's a partnership. I think when it goes like this, and it doesn't help anybody. And why would a nurse want to work there? And so how do we make them feel safe, valued, and actually empowered to not worry that someone might die that they can't get to the light? And so those problems go beyond but this is an act of desperation by the people who are bringing it forward, that they have professional standards as well. And never mind the professions, what about their moral obligation? The people who walked in having a heart attack or some other condition at the ER waiting to get somewhere in the hospital. And I think you better start saying, sorry, you're like 9 on a list of somebody can handle 5. And if your light gets answered, it's good luck. And we're still going to charge you, a lot of money to sit here and get that done. And so I am all in on a fix. And I urge the people with concerns to come forward and get after this. It's a good year to do it. There's still time. And Senator Murphy, I'm with you in the mission of this, and I'm with you on most of the bill. And I think you're looking for advice on how to make it work better. And so that's all I got. Thank you, Madam Chair.
Thank you, Senator Abler. Senator Bolden.
Thank you, Madam Chair. And I thank you to Senator Murphy for bringing this bill. In our hearing last night, we heard time and time again about how the medical care, the health care we provide in Minnesota is, the #1 benefit we can give to we can provide for our citizens. I believe that health care in Minnesota is the best in the world. And that can't continue if we don't have nurses at the bedside to provide that care. I, too, am a registered nurse. I've been a nurse for over 20 years. The first 10 years of that, I worked in a hospital, mostly in the ICU. And then for about the next 10 years, I worked in education and was away from the bedside. And last fall, I went back to the bedside in a hospital. And it has been eye-opening because many things stay the same over that 10-year, 11-year gap when I was away from the bedside, and a lot is different. I also have fairly recent experience being on the other side of the bed, having a child who was in the hospital for 2 months last spring, and just recently 5 weeks here this year. And so having both that experience of being the nurse at the bedside and being on the other side of that bed, I know that we are at a crisis point. It is where we are at is not sustainable. In my conversations with my colleagues and with nurses who were caring for my son, it is evident that we cannot stay on this path. Nurses are struggling for all of the reasons that we have talked about. With the moral injury that we have experienced over the last, certainly over the pandemic and even before that, with the mental health trauma that folks have experienced, with a lack of resources. There was one of the earlier testifiers said something that really resonated with me. The soul-crushing inability to provide care to people in their most vulnerable moments. It's heartbreaking. Nurses, we come into this profession because we want to care for people. That's who we are, that's what we do. And when you have so many patients that you can't do that, you can't provide the care that they need, all you can do is hope to keep your head above water and keep everybody safe. That's not enough. And it's not sustainable, and we have to do better. And so, Senator Murphy, thank you for bringing this bill. It is needed.
Thank you, Senator Bolden. Senator Liskey.
Thank you, Madam Chair. First, I want to start out with a thank you to every single person in this room that's a healthcare worker. I would say as we've heard, the pandemic has accelerated the stress and strain that all healthcare workers are feeling in hospitals, across clinics, everywhere. And the one thing that I will attest to is, as we've talked about, nurses are the first thing and last thing you remember about a hospital stay or any interaction in a healthcare setting. I can think of the last few times, I can actually remember the nurse's name from labor and delivery of both of my children. It was actually pretty exciting. It was the same nurse both times. Granted, one was born prior to COVID and one was actually born during the height of COVID, so it's a pretty scary environment, but we got to at least work with somebody that we knew and remembered. So these experiences that we've heard, the things that we're hearing, I feel every single thing that everyone's brought to the table. Of course, the tough question here is this bill exactly the way we want to move forward to fix the problems that we're hearing about? And I've read through it, and I think a lot of the things are very good. The things that I am concerned about and that I would like to ask Senator Murphy about are pretty straightforward. Is how much time do you think this will take away from the bedside by having these committees? How much time do these nurses now have to apply to outside of healthcare just to address these things?
Senator Murphy.
Thank you, Senator Wiklund, and thank you for your question. And I also remember the nurses who took care of me when I delivered my twins. They stick with you. That's right. I'm gonna ask Ms. Mortrude to talk about this because she has more fresh, hands-on experience about the time. I can't imagine it would be the amount of time that we spend in committee because we spend a lot of time in committee. But there is something about that I think is important. We're in a deadline week, and we are reaching our capacity as people to do our jobs and to do them well. And we have the ability to pump the brakes. We're not going to take any more bills. We're only going to hear this many. And I think I've been thinking about this a lot, there's a parallel, but the consequences are different, the choices are different. And we want to make sure that the hospitals also have the ability, they can't pump the brakes and say, don't come in our hospital. But we want to make sure that when patients, Minnesotans, come into the hospitals, that there are enough people there prepared to take care of them. So with that, I'm going to turn to Ms. Mortrude. Thank you for the question.
Ms. Mortrude.
Thank you, Chair Wiklund and Senator. There are many hospitals right now who have some sort of committee, whether it be labor management committee, nursing care delivery committee, and some of those nurses that serve on those committees are allotted time to do that work. As you heard from one of the hospital administrators, that there aren't many nurses that actually work 1.0. Most of them work, if they're 12s, a 0.9, a 0.75, all of that. And so there are extra days that are a day off. But if nurses could get the guarantee that they had a say in staffing, our belief 100% is that they would participate so that they know when they come in that they're going to be safe. And to address one of the concerns about that this was created without leadership, it's the individual nurse who gets assigned that patient assignment, and it is her responsibility to deliver safe care. And when that doesn't happen, even if a negative outcome doesn't occur, that nurse can be disciplined by the Board of Nursing for putting those patients at risk. And I don't know one administrator who has shown up at the Board of Nursing hearing to say, I forced her to do that, that's on me. So regardless, the fact that CMS does require the CNO to sign off on the plan, they are not the ones that go to the Board of Nursing and defend that decision to force those patients on those nurses.
Senator Liskey.
Thank you for the response. The one concern I'm seeing is I've had a couple statistics that I've pulled up, and the concern here is that with these attendance to committees, you do have full-time nurses who would want to be on the committees, and it could possibly threaten as much as 15% of their capacity. And at that number, you're looking at 70,000 Minnesotans annually not receiving care that they would directly need. And so with that concern, we have drastic numbers that we're starting to talk about. And so with that number, I know this amendment's going to probably get you angry, and it's okay. We're here to discuss it. And honestly, it's not here to be mean. And in fact, I hear this constantly of, well, I want to present a friendly amendment. I know that this isn't going to come across friendly, but the idea is to have a discussion. So with that, I'm going to present the A8 amendment. And Mr. Monahan, I'm going to need your help because this was the amendment prior to the most recent amendment we've changed to.
Senator Liskey offers the A8 amendment, and it will be distributed. Mr. Monahan, do you want to describe how it will fit in with the A3 being adopted, or do you want Mr. or Senator Liskey to describe his intent, and you can you describe how this will work in now that we've adopted the A3?
Madam Chair, I'll defer to the senator about describing the intent of the amendment.
Right.
It does need to be amended slightly to conform with part of the amendment that Senator Murphy and Senator Abler offered, because as I understand it, he wants to conform his amendment to part of what was done in the other amendment.
Senator Liskey, can you?
Sure. So I'll talk to the intent of the amendment, and then we'll work on the language of the amendment. So the intent of the amendment is to strike Article 2, as we've heard from the MHA and of those sorts. And I think the reason for striking Article 2 is not necessarily to say that the nursing ratios or the nursing staff doesn't need help. As we've discussed, I'm fully in support of finding a solution here. The concern is the way that the current Article 2 is written is that it's a pretty heavy mandate. And for me, I've never agreed that mandates are the solution to anything. You a lot of times find more of a solution by giving incentives. People are more happy to come to the table, have the discussion, and then we find a way to actually work to a solution. And like we heard from the testifier from Winona, they found the solution prior to a mandate. And maybe their solution isn't perfect, but it sounds like their solution is much better than the heavy-handed mandates that we're setting forth here with Article 2. And so then the other parts were talking about, the other part of the amendment is to talk about the public language. You've already stricken a big part of the public language. The only part that I wanted to kind of keep pulling out was the reports back to the commissioner, as I'm not sure where the commissioner falls into the discussion. And so my worry is that we're just pushing more paperwork into the commissioner's office, making the hospitals perform more, making the nurses have more paperwork to fill out, and those are concerns that I have there.
Senator Murphy, I'm struggling with how to have a better description, I guess, of what I see that it deletes Article 2. What is the remainder?
So
Senator Liskey.
Sorry, Madam Chair. Madam Chair, the rest of the language would stay in place. The little bit of stricken language would be in Article 3, Subdivision 15, I believe, basically taking out the paragraphs that force reporting to the commissioner. And like I said, it would be, what we're going to help with Mr. Monahan here is trying to conform to the language that already came in place in the rest of that subdivision.
Okay. First, let's, Senator Murphy, can you give us a response on the intent or the amendment?
Thank you, Madam Chair and members. I would ask respectfully that you vote against this A8 amendment, Senator Liskey. I appreciate your point of view, and I really do love the colloquial language around here about friendly amendments and not friendly amendments. And our job is to wrestle through the conflict that we experience together. And when we do it and do it well, I think we are showing Minnesotans that we are actually up for the job that they sent us here to do. So I understand and appreciate the context with which you're bringing this. From my perspective, it essentially eliminates the heart of this proposal. And as I started with my testimony, this is a many, many years effort to try and come to this legislature raising this question with each time more urgency, with each time more concern, and with each time approach that recognizes and reflects the criticism, the concern, the input, the critique from hospitals and from legislators, and having gone from the first proposal that was introduced back in 2007 or 8, which did include a fixed ratio, to this, which would say, hey, hospital administrators, nursing executives, and staff nurses in the hospital, we want you to come together and wrestle with this decision in your hospital, including the professional judgment of the practicing staff nurses in the hospital, is a much different approach, and one that I think fundamentally recognizes and reflects the responsibility and the judgment of everybody involved, with the goal of high-quality patient care. And I think we share that goal. I think if we take that section out, we remove the effort and the intention on the part of legislators to say, we want you to do that work together. And without it, I don't believe it will happen, because it hasn't happened since 2008. So respectfully, I would ask for a no vote.
Senator Utke, you have a comment on that?
Thank you, Madam Chair. Yes, I would like to comment on the amendment. The amendment does some good work. Getting rid of Article 3 or Article 2 is important. And I've got just one thing that I would like to add for a reason why. And this is a press release from December 6th of this past year, right as they were finishing up their bargaining. It says, nurse negotiation leaders with the Minnesota Nurses Association today announced that they have reached tentative agreements with hospital executives for new 3-year contracts for 15,000 nurses in the Twin Cities and the Twin Ports. This tentative agreement is a historic win for nurses and patients at the bedside. This quote was by Maye Quade, president of the Minnesota Nurses Association. The nurses came out, they just went through a bargaining process. They were extremely happy with what they received. To me, Article 2 is a so-called solution looking for a lot of problems, and I don't see anything good with it. That's why I would ask you to support this amendment.
Senator Murphy, comment?
Madam Chair and Senator Aki, President Mary Turner was one of our testifiers today and talked about the content of those contract negotiations, both the rejection on the part of the hospital administrators to take up the issue of staffing, and a recognition that in the content, and I can't speak to the content of the contracts, but she could, she's here, the progress that they've made was in one hospital, they were going to address or align staffing so it wouldn't get any worse than it already is. So while I think there were good efforts, real efforts on the part of the nurses in those hospitals that were at the bargaining table to address the staffing issue, they didn't make much progress at the bargaining table.
Senator Bolden.
Thank you, Madam Chair. Just briefly, I would advocate voting no on this amendment. I think this is an important piece of the bill, and certainly, I will say I actually am not in favor of fixed ratios, because a patient isn't a patient isn't a patient. But I appreciate the approach of this bill in that it is a conversation that includes nurses, and bedside nurses should have input and have a voice at that table to talk about the level of staffing for units, because they are the ones providing that care. And so I appreciate that it isn't just a fixed ratio, that it is a process and a conversation and a collaboration, including the voice of those bedside nurses, to get to what is best and safe for patients, because at the heart, this is less about nurses as it is more about patients. Thank you.
Thank you, Senator Bolden. Members, Senator Liskey, I would like to get to a vote on this amendment.
Thank you, Madam Chair. Just quickly and briefly as to why I brought the amendment, I have 17 emails from hospitals across the state, including the two rural hospitals in my district. They are both concerned of possibly having to close wings, possibly having to close the entire hospital. That's a very big concern, especially in my district, because the next closest hospital, which also emailed me, is over 45 minutes away from where I live. So this is a concern that all of the residents in the area where I live would then be without a hospital in any way response. So that's why I brought the amendment. That's why I'm here to represent those voices that are being heard. Thanks.
Thank you. Thank you, Senator Liskey. I would like to move to a vote on the amendment. Members, all those in favor of the A8 amendment, please signify by saying aye. Aye. All opposed? No. The amendment does not pass. The amendment is not adopted. Members, it's 20. Oh, I'm sorry. I just was going to give a little check on the time. It's 25 after 10. We are DFL members supposed to be in caucus, but I really would like to finish this. We do have another bill. Senator Maye Quade has a finance bill that we would just be laying over. And so I'm just going to ask if there's, I don't know if you have a number of amendments that you wish to discuss, or Senator Atke. Okay. Can they be done expeditiously? Thank you. Senator Liskey.
Thank you, Madam Chair. Madam Chair, I would like to move the A9 amendment. This would be the other half of the A8 amendment, strictly just trying to remove the language that we would be forcing reports over to the commissioner's office every time. So a little more friendly-ish approach. Again, we like to use that word a lot around here, so I just thought I'd offer that. And Mr. Monahan would be able to help us explain where this would fall and how it would change the bill.
Mr. Monahan.
Madam Chair, members, this amendment would, once it's amended, would remove the requirement on page 20, line 29, that the hospitals submit their action plans and most recent annual reviews of the action plans to the Commissioner of Health. And it would also remove the requirement that the Commissioner of Health compile the information in the reports or the plans and annual reviews submitted by the hospitals and compile that information into a report that is submitted to the legislature.
Thank you. Senator Murphy, or do you, I'm sorry, Senator Liskey, did you want to describe any further the amendment? Okay. Senator Murphy.
Thank you, Senator Wiklund. I would ask for a no vote on this amendment. I think it is important that the Department of Health, that has responsibility, regulatory responsibility for our hospitals, have access to this information, and that the legislature have access to the reports.
Any other members wish to comment on the amendment? Members, we will take a vote on Senator Liskey's, the A9 amendment. All those in favor, please signify by saying aye. Aye. All opposed? No. The amendment does not pass, the motion does not prevail. The amendment is not adopted. And Senator Etke.
Thank you, Madam Chair. I would like to offer the A7 amendment.
Senator Etke offers the A7 amendment. Senator Etke, do you wish to kind of start describing it for us, or?
Sure. If everybody's got their copy, or I guess they're coming here real close. What this amendment does, actually at the top of the amendment, if you just remember here just a couple minutes ago, Mr. Monahan described what was, I believe, in the A9 amendment, if I have my numbers correct. That top is the same thing. It deletes Article 2 and goes into the other part. The heart and soul of this amendment, though, is we are taking and addressing what we truly want for our nurses. We've got a workforce shortage. We've got all of this that we need to address and speak to. And we, and in this case our nurses, they're looking for help. This amendment is the Nurse Licensure Compact, which would help. We've had it before last year. It's something that will help put more nurses in our hospitals and our facilities. We are an outlier. We currently are one of, 5 states that build a fence around our state and, don't allow our nurses to go back and forth. We take, and as we even heard last night, about the number of doctors that we educate and train and get ready to go out and serve all of us as we have medical needs. 80% of them are trained here in Minnesota that, we have the same thing with our nurses. We train a lot of nurses. They go through their schooling, they graduate, but what do? A lot of them go right across the borders and get that multi-state license because we all know, in particularly younger people, but that age keeps growing. You don't have to, you can be quite old and you're still younger than me, so, but people move around 4, 5, 6 years in one place. We heard some of these 30-plus year services, which are wonderful. We appreciate everything you've done in these various hospitals and communities, but today's world is different. People are more mobile. And when they are more mobile, they want to move around and can move around. The Nurse Licensure Compact allows them to do that, but it allows them to come to Minnesota. We have great health care. We have great job opportunities, and we want to enhance the numbers and help grow those numbers. Currently, we sit at, we're short 5,000 nurses. The statistics that I worked with last year, and I don't have them all in front of me, but the hundreds of thousands of nurses we're short across the U.S. And when we look at the number of nurses we're training and educating today, we're not keeping up with the retirements. And that's why we're short 5,000 now. Where will that be in another 5 years? This is just something that would definitely help us be in the driver's seat and bring more nurses into the state and be able to take advantage of this labor pool. So with that, I would ask that you support the A7 amendment.
Senator Murphy.
Thank you, Madam Chair and members. I would ask for a no vote on the A7 amendment, in part because it deletes Article 2, and in part because it advances the nurse licensure compact. As I testified in the beginning, the purpose of this bill is to keep our nurses at the bedside. We're trying to retain our nurses. We do have lots of licensed nurses across the country, but we don't have licensed nurses enough practicing in our hospitals. That's the problem that we're trying to solve. And it would be awesome if we solved it in such a way that nurses from other parts of the country decided they wanted to come here and practice because they knew they were going to be able to provide high-quality care. So I don't believe that the compact is the solution to this problem, and I would ask for a no vote. Thank you.
Senator Bolden.
Thank you, Madam Chair. In addition to the comments that Senator Murphy just made, I also would just urge a no vote on this amendment, in part because it deletes Article 2. Also, perhaps this is a fair conversation to have, but I think we should have a full conversation about it. I don't think it should be in the couple of minutes that we are, have to it in this hearing now as an amendment onto this other bill, which has a different focus. And so, if we were to have this discussion, I think it should be a hearing on its own with abilities for testifiers and really a full discussion around this. And so because of all of those reasons, I would urge a no vote on this amendment, Madam Chair.
Thank you. Senator Atke, did you have any more to say about the amendment?
Thank you, Madam Chair. No, I don't have any more amendments, but I've got some questions that I'd like to ask of staff and the author.
Okay, let's move to a vote on the A7 amendment. Members, all those in favor, please signify by saying aye.
Aye.
All those opposed? No. The amendment does not prevail. The A7 amendment is not adopted. Now, Senator Atke, you have a question?
I do. Thank you, Madam Chair. And I'm going to let Mr. Albrecht get into his chair because I've got questions for him. So Thank you for coming. Mr. Albrecht, with the bill that's before us, are there costs in this bill that you see? In addition to what's, we've got a couple things listed at the end as appropriations, but additional costs department-wise?
Mr. Albrecht, I mean, I do see several places where there's reports and the Department of Health has responsibilities. Is there any other financial impacts that you'd like to point out?
Madam Chair and Senator Atke, I also see a number of requirements for the Commissioner of Health. The cost for those things would be addressed in the fiscal note. We have not requested one yet.
Senator Atke.
Senator Atke, Madam Chair, Senator Atke, we have not requested one yet.
Oh. Thank you, Madam Chair. That was going to be my question. If there was one that had been requested, but at this point there hasn't, do you anticipate with the author, Mr. Albrecht, requesting a fiscal note soon so that we'd see what this is? And then, well, I'll stop there.
Senator Atke, yes, we will request a fiscal note. This bill does need to travel to multiple other committees, so we also acknowledge that, there's work that will go on the bill as it moves forward.
Okay, and I'll kind of wrap up with this next question then. The fact that it does have additional stops, will we see this again once it's made its travels and come back here? Because it's going to have fiscal costs. Will we get a chance to look at those and act on it?
Senator Atke, I haven't finalized the path with Senator Murphy's input. Yes, there are budget impacts that would come, from the Department of Health or would have to go to the Department of Health. I mean, I think it would be a possibility for it to end up here, back here, so that we would be the ones addressing the appropriations that would need to go to the Department of Health. But I just haven't finalized that path with Senator Murphy.
Okay. Thank you, Madam Chair.
Members, any other questions or discussion? Seeing no other questions before us, I'd like to move to a vote. Oh, Senator Murphy, did you have any other closing comments?
Madam Chair and members, given the time, I will just say thank you so much for making so much time for this important issue. And I do want to thank Senator Abler for his partnership and co-authorship on this. I really appreciate it.
Thank you, Senator Murphy. And yes, it's been a really good discussion today. I think it was really valuable to hear the perspectives of all of those involved, and I appreciate your commitment to keep working with many. From my perspective, I signed on to the bill because I also hear from constituents who are experiencing the results of this retention crisis that testifiers have mentioned. They're working in situations that they don't feel safe, and they feel that we need to do our best to try and address these situations. I think the bill is comprehensive. I like that it approaches this from the different facets that are involved in trying to bring a good solution to this problem. So appreciate bringing it forward, and I also appreciate that you're willing to continue working and discussing with all of those involved. The bill today, we will be moving the bill to the Labor Committee, and then I'm not sure the next stop after that. So members, let's see, who would like to make the motion? I didn't. Senator Bolden, would you please make the motion for that Senate file, excuse me, 1561 as amended, be recommended to pass and be referred to the Committee on Labor?
So moved, Madam Chair.
Members, on that motion, all those in favor, please signify by saying aye. Aye. And all those opposed?
No.
The motion does prevail. The bill, Senate File 1561, as amended, is passed and will be moved to the Committee on Labor. Members, we have one other bill that we'd like to quickly get through. It's Senator Kupec's bill, and he has a testifier here. If we can do that kind of rapidly, this bill will be laid over for possible inclusion in a budget bill.
Sure.
Thank you, Senator Kupec. This is Senate File 2353. Please go ahead and present your bill.
Sure. Thank you, Senator Wiklund, and I will try to be as brief as I can, Madam Chair. So Senate File 2353 is asking to include into basically to have people talk about, be trained up and talked about Alzheimer's in the community health setting. So Alzheimer's disease, racial disparities in 2020, 99,000 Minnesotans were living with Alzheimer's disease and another form of dementia. That number is expected to increase by 21% by 2025. Elder care system is very complex and fragmented, scarce resources, complex system to determine the eligibility for public benefits makes it very hard for Minnesota elders to access resources or even diagnose Alzheimer's and another form of dementia. These barriers are more pronounced, particularly in communities of color. CHWS, our health equity workforce, comes from communities they serve, usually sharing identities, geography, and experiences with their clients and patients. This commonality makes CWS uniquely qualified to relate and provide support to individuals in the community. So just looking quickly at the bill, basically it just adds in to the bill that the Commissioner of Health will collaborate with interested stakeholders and develop a program for training community health workers to recognize and understand Alzheimer's disease and dementia. And then I have a couple of testifiers too.
Thank you. And I am seeing Nicole Goins. I'm sorry if I'm mispronouncing that. Please state your name for the record and begin your testimony.
My name is Nicole Goins. I am a community health worker with Volunteers of America, Minnesota, and Wisconsin. I work with the Culturally Responsive Dementia Caregiver Support Team. We provide education on blood pressure, diabetes, heart and brain health. Also, we provide memory screening in the community as it can be a risk factor for early onset of Alzheimer's. Memory screening is important to have to detect the early signs of dementia. Age, family, history, and genetics are the main factors that increase the development of Alzheimer's disease. I provided a 3-minute memory screen test, which consists of memorizing 3 words, making a clock, and setting the clock to 10 past 11 on a client. Unfortunately, the client did not pass the test, and I was able to refer the client to a physician that specializes in brain health. As a community health worker, I was able to provide resources and support for the client as they battle this terrible disease. I take pride in helping older adults in need, which may be finding resources for respite, adult daycare, clinic, food support, transportation, education, or just to listen. Thanks to my training, I can go out in the community and help families and their loved ones who have Alzheimer's disease. Thank you.
Thank you for your testimony today. Mr. Smith, did you have additional testimony, or just are you here for questions?
Madam Chair, given the time, I'm here just to answer any questions. Thank you.
Okay, thank you. Members, do you have any questions for the bill author? Senator Etke.
I will bring up the same one I typically do as I look at this. Where are we at with a fiscal note on this? Because it appears that there's quite a bit of spending when we're involving the colleges and universities and creating a training program and all of that. Anybody know, has a note been ordered or requested, and any idea what it might be for total?
Senator Kupec, I do not believe we requested one on this.
No.
It has not been requested yet, Senator Etke, but we will look at requesting it immediately, because we'll lay it over so that we will have that information before we would take any further action on it. Did you have any other questions? No? Senator Kupec, any other thoughts about that you'd like to present about the bill?
No, I'd just like to thank my co-authors, which are about half of the rest of the committee, so thank you for your support.
That's true. Thank you. I really appreciate your testimony, and it does seem like community health workers are really in a position that they could play a really valuable role in helping to educate people that they work with in the community, and it does seem like if the training was available, that there would be, workers who would appreciate having that. As you said, you're able to provide better services and in the community as you have had the training. So thank you for your work and for coming today.
Thank you.
And members, with that, we will lay lay Senate File 2353 over for possible inclusion in a future bill. And seeing, and just to make people aware, Senate File 1274 was Senator Maye Quade's bill. She wasn't able to stay due to another appointment, so we will take up Senate File 1274 tomorrow. And with that, with no other work before us, this meeting is adjourned.
Thank you.